Welcome to episode 98 of Dermatology Weekly. I'm MDedge editor Elizabeth Mishkati. Coming up in the peer-to-peer portion of the program, Dr. Vincent DeLeo will be interviewing Dr. Amy Paller and Dr. Jennifer Bowles-Scott about biologics for pediatric psoriasis and atopic dermatitis. As always, the peer-to-peer portion of the show will be after the news. And in the news this week, we have stories on the risks of pregnancy associated with Pityriasis, rosea, and results of a study on adjuvant immunotherapy in patients resected stage 4 melanoma. In the first story, a retrospective study published in the Journal of the American Academy of Dermatology found that pregnancy complications in women with pityriasis rosea were relatively minor. Using electronic medical records from the University of Virginia, Northwestern University, and the University of Mississippi, the authors, who were from those three universities, identified 33 women who developed PR during pregnancy. Diagnosis of PR, a papulosquamous skin eruption associated with human herpes virus 6-7 reactivation, was based on history and physical exam. 8 of the 33 women, or 25%, had birth complications, but there were no cases of miscarriage, spontaneous abortion, or fetal death. Rates of preterm delivery and oligohydramnios were 6% and 3%, respectively. There were no cases of spontaneous pregnancy loss and clinically detectable pregnancies. The average onset of PR during pregnancy was earlier among women who had complications compared with those without complications. 10.75 versus 15.21 weeks gestation. But this difference was not statistically significant. The investigators noted that their findings differed from the most recent study of PR in pregnancy. In that study of 60 patients, there was a higher incidence of overall birth complications at 50% and a higher incidence of neonatal hypotonia at 25% and a 13% miscarriage rate. While the new study had limitations, including its small sample size, these results suggest that birth complications associated with PR may be lower than previously reported, the authors concluded. They added that more research is needed to guide future care and fully elucidate this possible association. In another story, Dr. Merrick Ross reported on the encouraging results of the MDedge study of adjuvant immunotherapy in patients with stage 4 melanoma. The multi-center German double-blind placebo-controlled phase 2 trial randomized 167 patients with resected stage 4 melanoma and no evidence of disease to adjuvant nivolumab plus placebo, nivolumab plus ipilimumab, or double placebo. Relapse-free survival was the primary outcome. The patients who received adjuvant ipilimumab and nivolumab had amazing 24-month outcomes, according to Dr. Ross, who is professor of surgical oncology and chief of the melanoma section at the University of Texas MD Anderson Cancer Center in Houston. At that time point, relapse-free survival was 70% in that group versus 42% with nivolumab and 14% with placebo. Toxicity, however, was significantly greater among those on both agents. Treatment-related adverse events led to medication discontinuation in 62% of the dual adjuvant therapy group, compared with 13% of those on adjuvant nivolumab. The results were reported at a virtual forum on cutaneous malignancies, jointly presented by the Postgraduate Institute for Medicine and Global Academy for Medical Education. And that's it for the news. Coming up, Dr. Vincent DeLeo and Peer-to-Peer. Welcome back to Dermatology Weekly. It's time now for Peer-to-Peer. Please welcome Dr. Vincent DeLeo.
Today we're talking to Doctors Jennifer Scott and Amy Paller about biologics in pediatric psoriasis and atopic dermatitis. Could you both introduce yourselves for our listeners today?
Sure. Hi, I'm Dr. Amy Paller. I'm the professor and chair of dermatology at Northwestern and also professor of pediatrics, and I work at the Ann and Robert H. Lurie Children's Hospital of Chicago.
And I am Dr. Jennifer Scott. I am a clinical research fellow in the Department of Dermatology at Northwestern University.
Great. Thank you so much for joining us today. Let's get started. What developments have led to the growth of biologics for psoriasis and atopic derm in children?
Well, I'll start with that. Unfortunately, with children, the use of medications often follow what's available in adults. And that certainly has been the case. With psoriasis, of course, we have seen tremendous growth in the use of biologics for moderate to severe psoriasis. But interestingly, even though the very first of those, etanercept, the TNF inhibitor, were studied back in the late 2008, 2009, they really didn't become available until the last few years with FDA approval for children. Of course, many adolescents have psoriasis, and so the need's been huge. Unfortunately, since that time, there's been a growing interest in developing biologics for pediatric psoriasis. In atopic dermatitis, of course, the majority of patients have their onset actually during infancy and early childhood, and many of them have moderate to severe disease. So it's been a great need to develop more targeted, more effective therapy for atopic dermatitis. The advent of dupilumab as the first biologic for atopic dermatitis, of course, came first in adults, but I'm really delighted that the testing has been done and it's now available down to 6 years of age as the first biologic for children with atopic dermatitis.
So what's new in psoriasis in pediatric patients? I mean, what are we looking forward to in that group with that disease?
With respect to pediatric patients, of course, children of any age can have psoriasis, although predominantly it is a disorder that occurs during the second decade of life and almost linearly increases in terms of its frequency with advancing age. What we've seen that's new really is the development primarily of new biologics that have been available for adults for quite a while, but have recently been showing success in double-blind randomized clinical trials in children of various ages. And several of them have more recently come on the market. For example, the first was etanercept. We had such a long period between when etanercept was available for adults versus children. We still, in the United States, don't have adalimumab FDA approved, but I'm delighted to say that ustekinumab is now available for children as young as 6 years of age. And most recently, ixekizumab has become FDA approved as young as 6 years of age. Others are in testing, and I'm sure will follow, but this has been particularly welcome news, first of all, to have the flexibility of having choices, but also because, as we've seen, progressively, we've seen the newer biologics being more and more effective in both adults and in children. So we're able to take some of the more effective ones and apply them to our children and adolescents with psoriasis. And that means that we're getting more and more that have PASI 90s and PASI 100s, and we keep raising the bar in children as well as in adults.
That's fantastic. And what about with atopic dermatitis?
Atopic dermatitis, such a huge need for better, more targeted agents for treating children and adolescents with atopic dermatitis. Atopic dermatitis, of course, just like psoriasis, is life-altering. And here we see that devastating itch that affects sleep and very much affects school in so many ways. Dupilumab is the first one out of the gate, and it's really the only one available right now for adults that is targeted, but has recently, back in May, become available for even children 6 to 11 years of age, and is currently in trials for those who are under the age of 6 and as low as 6 months of age. There are others to follow as well, and so we're quite excited about that, both new topicals and new systemic agents that will be available. Do you know that when we look at databases through insurance companies, for example, 24% of children with atopic dermatitis have been treated with a systemic steroid. And That's in contrast with 0.5% of those being treated with an immunosuppressant. We've been very hesitant to use immunosuppressants because of their potential side effects. But there's still a lot of use of systemic steroids, which many of us feel is almost contraindicated in children because of the high risks and also the rebound when discontinuing them. So the availability of non-steroidal, non-immunosuppressant agents that don't even need labs for monitoring is a welcome change.
Yeah, so let's delve a little more deeply into what the advantages of biologics are as compared to the standard treatments that we've had before for children.
Absolutely. So as Dr. Paller mentioned, there is evidence of efficacy in using biologics to treat pediatric psoriasis and atopic dermatitis. In addition to this, biologics are more convenient to use. They require less monitoring and are associated with fewer treatment-related toxic effects than conventional agents in children. Because these biologics target specific cytokines in the inflammatory cascade, they are generally associated with less immunosuppression. Though some adverse effects have been reported with use of biologics, they are generally mild and include skin or injection site reactions, respiratory tract infections, and eye irritation. In terms of lab monitoring, as Dr. Paller had mentioned, systemic agents such as methotrexate and cyclosporin require baseline and ongoing assessments. Lab monitoring can be as frequent as every few weeks when first starting therapy, then spaces to every few months. However, for biologics, baseline monitoring for tuberculosis is recommended, and then yearly for TNF-alpha inhibitors, unless the individual patient is at increased risk and would require additional monitoring. No tuberculosis testing is needed for dupilumab, and no other lab monitoring is recommended for any biologic in children unless warranted by their individual risk. Finally, the dosing schedule for biologics is much more convenient. Most biologics are administered every 2, 4, or 8 weeks compared to a daily or weekly regimen required of traditional systemic agents.
I think that's marvelous, all the advantages to using the biologics as compared to the older standard treatments in children. What are the cost considerations that dermatologists need to evaluate when prescribing biologics for children?
Cost is really the downside of biologics. We know that it can cost $30,000 to $60,000 per year for a course of biologics, whereas one can look at something like methotrexate, which is very inexpensive, and even cyclosporin, or when we're talking about psoriasis, a retinoid like acitretin, we're still just talking about a few $1,000s at most, and throw in a little bit of lab monitoring. So cost to society, cost to individuals, and quite frankly, in the United States, we know that many of our families, even with insurance, are left with a large monthly fee that's unaffordable, even with help from companies, if that's available, for particular biologics. So we have to keep that into consideration when ordering them.
So one thing that physicians always ask is about vaccinations, and they ask that in adults, but it's particularly important in children when we're considering biologics. Can you delve into that a little for us?
Absolutely. And really, all concerns about vaccine administration should be discussed with the child's doctor. The thing with biologics is that live vaccines should not be administered while undergoing therapy. Fortunately, though, most live attenuated vaccines, such as MMR and varicella, that are part of a routine pediatric vaccine schedule, are completed by age 4. Other live vaccines, such as the intranasal influenza vaccine, herpes zoster, which again is an adult vaccine, and BCG, which is not generally recommended for use in the United States, should not really come into play for the pediatric population. In the event that live vaccines are needed as part of a routine or catch-up schedule, they should be administered prior to starting immunosuppressive therapy, ideally at least 4 weeks before starting that agent. Inactivated vaccines, such as the flu vaccine and the remainder of the routine childhood immunizations, may be given to people taking biologics. And for example, the flu vaccine in particular is specifically recommended for these patients and their household contacts. Another thing to consider are household contacts. Individuals living in the same household as immunosuppressed patients, as well as any other close social contacts, are advised to keep their standard vaccines up to date and receive annual flu shots.
Thank you. Now, we've had a really great discussion, and I would recommend to our listeners that they look at the marvelous table that you've put together about biologics now and on the horizon. But can you cover a little bit for us what's on the horizon in biologics in the pediatric age group?
I'll be happy to take that one. There's a lot on the horizon. In fact, there's so much more on the horizon than we currently have available in pediatrics. When we're talking about psoriasis with respect to the biologics, of course, many that are currently available for adults are in testing or have recently completed testing and hopefully will move forward. And we're talking there about anything from secukinumab and brodalumab to the IL-23P19 specific antibodies, which we're also looking forward to because they look highly efficacious in adults. When we're talking about atopic dermatitis, of course, everything beyond dupilumab is still in trials or moving towards hopeful FDA approval. So that includes the IL-13 inhibitors. The tralokinumab is already finished its studies in older children, adolescents, and lebrikizumab is just starting them. We know also nivolumab, which is the itch-specific cytokine, is in studies now with adolescents. For the JAK inhibitors systemically, we're talking about really abrocitinib now completing its adolescent trials. The upadacitinib included. Adolescents is about a third of the patients in their pivotal studies. So we have that data coming out now as well. So very exciting to think about what's coming. And I've just talked about the systemic agents. There are also topical agents, which are very exciting as well. And of course, in pediatric use, topicals are of paramount importance as agents to try to avoid having to go to systemics. So all of that's on the horizon, and we're really looking forward to both seeing the results of trials and then having an armamentarium that allows flexibility for family.
It is an exciting time, I guess, for treating children with significant disease with psoriasis and atopic dermatitis. And I want to thank both of you for joining us today. Anything else you'd like to add?
Well, I just want to add the consideration that these are all new. One of the issues, of course, in pediatric practice is safety. And safety really trumps anything else that we might be considering when we're thinking about the use of these various agents. None of them have very long-term data. So that is one thing that we're going to be very carefully looking at. And when we're comparing these various agents, we may need to swap out a little bit of efficacy for that long-term safety as we're moving forward. We also really want to learn more about how to best use them. A difference in children versus adults is that many parents are hopeful that children will outgrow their inflammatory skin disorders. And that means that with all of these agents, we want to try to stop and start, whether that be a biologic that we might want to taper to a lesser schedule and try to go off of for a while, or whether that's an oral agent that we might stop and see what happens, or figure out how to use best as a maintenance agent. Lots of questions, but we're excited about the future.
Well, again, thank you both for joining us. And I'm sure our listeners will enjoy what you've shared with us today. So thanks a lot.
Thank you for the invitation.
Yeah, thanks for having us.
That's it for episode 98 of Dermatology Weekly. The peer-to-peer portion of the show is produced by MDedge editor Melissa Sears and editor Alicia Saunders. All of our podcasts are produced by Nick Andrews and MDedge executive editor Kathy Scarbeck. I'm MDedge editor Elizabeth Mishkati, and this is Dermatology Weekly.